Just wait a minute, Ratnesh.
Yeah, I'm just sharing the screen, sir.
Ah, okay.
Yes, we are live now. You can go on.
Okay. Good evening, everybody. Welcome to this webinar for today, which is again aimed at DNB students and postgraduate students. And today we have Dr. Ratnesh, who's a consultant with us at Varus Hospital, who's going to talk to us about total knee replacements in knees with a varus deformity, how you tackle them, and tips and tricks on how to get it right. So over to you, Ratnesh.
Yeah, thanks, sir. Good evening. Today I shall discuss about the TKR in varus knee. Varus is the most common knee we perform nowadays, and I think 80 to 85% of the primary knee done in India are varus knee. So let's learn some tips and tricks what to do in varus knee. The successful TKR depends upon soft tissue balance, both medial and lateral side, proper bone resection, and gap should be balanced both in flexion and extension. Our goal of surgery is to get rectangular, symmetrical flexion and extension gap with optimum tissue tension. Preoperative planning. First, you should see the patient for any kind of systemic disease, or if the patient is diabetic or hypertensive or has a cardiac problem. You first tackle all those things, refer the patient to physician, take the cardiologist opinion, and just patient should be fit for the surgery because it's a planned surgery and it's a big surgery. So patient should be fit for the surgeries. Then from our side, we should obtain a full length lower extremity AP and lateral view. Should have evaluate anatomical and mechanical access, especially in cases of excessive femoral or tibial bowing or in malunions. It also helps to obtain the desired entry hold position for femur for intramedullary guide. If there is severe deformity in metaphysis, old ununited fracture, severe rotational deformity, in those cases, it is better to go for the robotics, or you can uh, plan your cuts uh, using the other computer assisted system, because in those cases femur guide or tibia guide will not help you to obtain a good position of the implant. In both AP and lateral X-ray, you should look for the bone loss and plan accordingly. You might need to manage those bone loss with some augments or some extension rods. Those things should be present on the table on the day of surgery. So this all things should be planned. Then check for the magnitude of the deformity, whether it is correctable, passively correctable, or it's not. Many are deformities, especially in very old cases, they are passively correctable. In those cases, you don't need to release too much. Check for the FFD, whether it is correctable or not. Skin condition should be checked first, whether there are previous surgical scars are present or not. If there are multiple scars, you should seek some opinion from plastic surgeon also. Where should we plan this, our incision to avoid any skin complications later on. This is the algorithm of surgery what we are doing. We have to release from medial side. So first medial release, then remove osteophyte, then we do the bony cuts, then further medial release if required. Then we have to deal with the bone loss and should always avoid over resection and over release. A medial parapatellar approach is preferred. People are using other approaches also, like Sylvester's or mid-Vestus approaches, but we are not. We are doing all TKRs with medial parapatellar approach. It's extensile. So in medial parapatellar approach, a sequential release is performed until the medial structure is the length equalize that of the lateral structures. So the tissue tension on both medial and lateral side should be equal. Step one is to create a medial sleeve. You can use scalpel blade or you can use the electrocautery also. We have to subperiosteally elevate the medial sleeve, including joint capsule and deep MCL. Continue release till the metaphyseal flare and up to the posterior medial corner of the tibia. Follow the Ransal maneuver, that is progressive external rotation and flexion of tibia during your release. Remove all the osteophytes from both from tibia and femur because they used to tighten the medial collateral ligament. Once they are all removed, it has a good releasing effect. Remember to remove the posterior femoral and posterior medial tibial osteophyte also because they tighten the extension gap. Release the PCL if you are planning for PCL substitution. If you want to retain the PCL in CR knees, PCL should be left intact. Then the bony cuts, the usual is the tibial cut, femoral cut, and we balance the joint and apply the implant. Let's go one by one. You can do tibial cuts or femoral cuts, anything as you wish, but most of the surgeons prefer to use prefer to cut tibia first. So we use the extramedullary jig. You can also use the intramedullary jig to place the jig in correct alignment with the help of alignment rod. And then plan your cut. Planning of cut is done according to the reference from the upper surface. You can take either 2 mm or 8 mm. If you want to take the cut with reference from normal side, that is lateral side in case of varus knee, you can take 8 mm from lateral side, or you can use 2 mm from medial side. In case of severe bone loss, it is better to take cuts from lateral, referencing the lateral tibial plateau with 8 mm or 9 mm, whichever is company design jig. You can take the cut from lateral, taking the reference from lateral tibial plateau. Once tibial cut is made, distal femoral cut is to be done. This is, here we usually use the intramedullary jig and take the distal femur cut. Then you check the extension gap. Once both tibia and femur is cut, check for the extension gap. Then you check if it is tight both medially and laterally, and FFD is also present, or suppose it's not going in. Your gap check is that block is not going in for gap check. Then take extra 2 mm from 2 mm or 4 mm, whatever is required from distal femur. If it is tight only medially, then you have to go for the soft tissue release, medial soft tissue release. Then further femoral cuts are planned. You can take reference from posterior or anterior. The cutting jigs are designed for anterior referencing and posterior referencing. In this picture, we are showing the posterior referencing jig, while most of us are using the posterior referencing jig. Reference is taken from posterior condyles, and the cutting block is applied. Once the cutting block is applied, then you check the gap between the lower portion of cutting jig and the upper cut portion of the tibia, and see if the flexion gap and extension gap are same or not. If they are same, you can go with the cuts. If they are not same, if the flexion gap is tight both medially and laterally, then you have to downsize the femur to increase the flexion gap both medially and laterally. When we are downsizing the femur, we are cutting more from the posterior. If we are increasing the size of the femur, we are cutting less from the back. And if it is tight only medially, it is better to move medial cutting jig fixation pin forward till the gap is balanced. Like you can understand in this picture. Suppose first fixation pin was in reference to this hole, and medial flexion gap is so much tight, we will move this pin forward, suppose here, and then we shall cut. In that case, we can maintain the medial tight medial flexion space. Once you cut, then check for the flexion gap. The flexion gap and extension gap should ideally be same to obtain a good long-term success of the knee. Now next step is to release from posterior side. A 15 osteotome is used to release the posterior capsule and remove the osteophytes. By doing this maneuver, not only the flexion deformity is corrected, but it also increases the medial joint space. If joint, uh, if tightness is still medial, then the next step is to release the semimembranosus and posterior medial capsule from posterior medial side of the tibia. If the joint is still tight in extension, medially in extension, during varus valgus stress, we can release the posterior oblique ligament from posterior medial tibia. This can be done best in figure 4 position. If the joint is still tight medially, we can follow this maneuver, just undersize the tibial tray and lateralize it, shift it laterally, and remove all the medial osteosclerotic bone. By doing this maneuver, we can increase the working length of MCL. Also, we can manage the bone loss, posterior medial bone loss. Like this, we cut the bone, so we don't need to manage this bone loss here. This works like this. Once in very tight knee, we undersize the tibia, lateralize it, cut the medial part, and in this way the working length of the MCL increases and the joint is well balanced. The last step is to release the MCL. The MCL release should always be avoided because this is the only strong medial constraint. So access the flexion extension gap using lamina spreader, trial component, spacer block, check in varus and valgus position. If tight in both, release subperiostelis, superficial MCL or proximal tibia, but do not do it completely from distal tibia. Although some surgeons advocated to release it from the distal tibia also, but it leads to gross instability. So it should always be avoided. Alternatively, you can pie crust the MCL using 16 or 18 gauge needle. If the joint is tight medially only in extension, then only posterior fibers need to be released. And if it is tight in flexion, only anterior fiber needs to be released. Alternatively, you can do the pie crusting also. So these are the structures which are responsible for tight extension gap and flexion gap. So to increase the extension gap, you can release this sequentially from superficial MCL, from deep MCL, then posterior oblique ligament, semimembranosus tendon, base, anteromedial capsule, and mediogastrocnemius head. But to increase the flexion gap, you have only two or three options. First is to correct the flexion gap while cutting the distal femur. Second is to shift and resect so that you can increase the working length of MCL both in flexion and extension. Or the last resort left is to release the anterior fibers MCL. This is the last resort to take care of the tight medial flexion gap. In severe varus knee, even after doing everything, there is some residual lateral laxity is always present. So how to deal with that? One idea is that the IT band is a dynamic stabilizer, so it won't be a much problem while walking. IT band will take care of any lateral laxity present. Or you can release more from medial side and increase the size of the poly, so it can accommodate both medial and lateral side. or you can do the LCL advancement. And sometimes you have to manage the bone loss. So if there is severe bone loss which is not contained, then you might need to use some wedges or the augments which are present. You can add that to the tibial base plate, and to support that you need to add the extension rod to stabilize the tibial base plate. Now coming to the correction of fixed flexion deformity, which is usually present in varus knee. It can be uh, graded into grade 1, grade 2, grade 3. Grade 1 is up to 30°, grade 2 is 30 to 60°, and more than 60° FFD present is grade 3. So in most of the varus knee, you will find the fixed flexion deformity. In most of the cases, the deformity corrects after anesthesia, because that is in response to the most of the deformities are due to the spasm present in the hamstrings, or sometimes there is tight cap. Some patients, due to pain, they tend to keep their limb in flex position. But some of the deformities are correctable just by the anesthesia. If the deformity is present still after anesthesia, remove posterior osteophyte added to the capsular recess. Then stripping of adherent posterior capsule after bony cut, and then over resection of it. If by removing all posterior osteophyte and releasing all the posterior capsule attached to the posterior condyle, if the FFD is still present, we can over resect the distal femur by 2 mm if extension gap is tight even after soft tissue release. In grade 1, this is maximum which is required. But in case of more severe deformity in grade 2, we start with over resection of 2 to 4 mm from the femur, and soft tissue release as in grade 1 is done if the limb is still tight and going in flexion. Then elevate posterior capsule even up to the linea aspera. Then elevate medial and lateral head of gastrocnemius, and this should be sufficient to correct the deformity. If still the deformity is present, you can transversely dissect the posterior medial capsule in refractory cases. Once the deformity is corrected, knee has to be immobilized in a splint for 3 weeks and night splint for another 3 months. Every FFD tends to recur even after surgery. There is high tendency of recurrence of this deformity, so maintenance of the correction of deformity is also important, and knee immobilizer or sometimes cast is used. In severe FFD more than 60°, we start with ovary section of distal femur by 4 mm. Soft tissue releases as we do in grade 2. In severe releases, we should be ready with the constraint implant, because mid flexion, it can lead to mid flexion instability. Collateral ligament laxity may need to be tightened or advancement. In some cases, release at hip may be needed to correct the FFD, and patient has to put his limb in cast in post-operative period to maintain that correction of deformity. Thank you.
Thanks, Ratnesh. That was very succinct and to the point. I'm sure there's a lot of useful information there for people to take away. So I would open the session for questions, especially from the DNB students.
Sir, good evening, sir.
Yeah, Gautam.
Sir, question is role of pre-op traction in varus knee with FFD.
I don't think there is definite role. Initially, in previous days, we used to do this, but you have to release it anyhow.
Yeah, so I think sometimes if there's an element of some of the rheumatoids who develop very severe flexion deformity, you may be able to get some correction with traction. Otherwise, it doesn't tend to help a lot. So you need to give them traction and medication for, so it could be a combination of a bit of spasm as well as pain, which causes it to stay in that position. So yes, but eventually you need to make sure you've released adequately at surgery. Otherwise, you're going to get a problem. So,
Okay.
so if you can get some correction with traction, which is not sort of possible clinically. The thing is, under anesthesia, some of them straighten out quite a bit. Okay, so because part of it is spasm. If they're fixed contractures, then anyway you're going to have to release them.
Yes, sir.
Yeah. Any other questions?
Sir,
So,
good evening.
Yes,
Sir,
yeah.
Avinash, okay.
Sir, I want to ask about, sir.
Keep it here.
Where is
Yeah.
that?
Sir, unicompartmental. Sir, in case of varus deformity, if unicompartmental osteoarthritis is there, sir, can we do unicompartmental knee replacement in place of osteotomy? What we are doing?
Yeah, definitely, if the disease is confined to only medial compartment and ACL should be working, deformity should be less than 5 degrees or 10 degrees, and it should not be an inflammatory one, you can go for unilateral knee replacement.
Yeah, so I think there's they're kind of slightly different indications for the two. So if you have a significant deformity, especially in a young active patient, then you would veer towards osteotomy. If it is a slightly more elderly patient with not so high demands, then you would veer towards a unicompartmental knee. The things you have to be careful with unicompartmental knee, especially if there's any involvement of the opposite side or even the patella. Okay, HTO, you can sometimes extend the indication because by improving the alignment, you may prevent the progress of the disease and you're not, in a way, burning your bridges. While uni, I think if it goes wrong, it's almost like doing a revision knee after that. Yeah.
Okay, so,
They say it's one compartment. Usually, by the time you get everything out, the cement out, you're eventually almost doing a revision knee.
okay, so if the patient has varus thrust in addition to varus knee, sir, then the management, is it different or is it same?
So varus thrust is just will tell you that this thing is going to progress. Okay. So I have there's noise coming. If there's a varus thrust when the patient has already got varus and he's got unicompartment osteoarthritis, it's a sign that that's going to progress more rapidly than a patient without varus thrust. And I think there are a number of studies to show that.
Yeah, we have to sometimes add, we have to release more from the medial side, and we also should use, in those cases, we should augment it with some extension rod because chances of failure is very high. And second, in cases of varus thrust, we need to maintain this after in post-operative period because these deformities tends to recur after the surgery. So if we keep the limb straight in like in Knight's plane, gradually all the lateral structures will shrink and knee will be gradually will be stabilized. So
usually they adapt.
Maintenance is more important in those cases.
And so in pre-operative planning, sir, how to know that deformity is intra-articular or extra-articular? Is it in femur or tibia? So that just
you take a long leg view, mark both mechanical axis and anatomical axis, then you will find whether it is intra-articular and extra-articular. Even some extra-articular deformities are managed intra-articularly during the surgery. because in elderly patient, especially in gross osteoporotic, you will find tibia vara. So in those cases, we are not correcting the tibia vara, rather trying to correct those deformity intra-articularly, but up to some extent. We cannot accommodate more of the extra-articular deformity in intra-articular correction.
Yeah, I think some people are also adding osteotomies to the correction. So you do a intra-articular correction for your knee replacement, but also do an extra-articular osteotomy if the tibia vara is too severe. Okay, because you can't correct everything at the knee in those. But by and large, we try to correct sometimes a little more at the knee rather than do a second osteotomy. But there will be cases where ideally you should do a separate osteotomy because otherwise you'll get a zigzag kind of deformity.
And sir,
clinically intra-articular, extra-articular deformity को differentiate कर
Clinically, you have to
सकते हैं
see,
सर.
clinically you can't even make out if it's in the femur or the tibia. Okay, to be honest, you need to do your alignment films and do your measurements on that to check the axis both of the entire limb and of the femur and tibia individually, and also the joint axis. Okay, so all these things you should ideally be doing. Today you can do it on computer aided software, and I think we already have it, but we are not using it as much as we should. Okay, so I think I think because they did the training and went off, and then in between we had this thing. So I think we should get back to actually looking at those programs and doing some pre-operative measurements of all the deformities and recording them before we do the knee replacements, as well as the tibial osteotomies that we are doing.
yes, sir. For that one, sir, one Android application for rough guide Angulus is also there, but
yeah, so there are a lot of softwares which are available free on the net as well. There's Bone Ninja, there's this Android thing, and I think you youngsters should be working on this. Yeah,
yeah.
I mean, you're too old to be now doing all this sort of thing. Okay?
And sir, just one question
So,
from
sir,
the very basic.
So,
Yes.
sir, by uploading the orthoscanogram X-ray on the web, we can calculate the deformity and know the where is pora.
So why aren't you doing it?
Yeah.
That's what I'm saying. Your youngsters should be the ones leading the way in this, okay?
And sir, one question from the basic, sir. What is our aim in varus knee? Is it in the coronal plane? It is just 0 degree, or it is slightly valgus, or in the sagittal plane? What should be our aim? Is it slightly flexion, or is it 0 degree of that extended knee?
First of all, you should never try to make a varus knee into a valgus. Both either in TKR or in correction. Because if you convert varus knee into valgus, it will be painful. It's a natural tendency of knee to go painful. Valgus means up to 1-2 degree valgus is well accepted. But if you try more than that, it will be painful. Second thing, we try to make a 3 to 5 degree posterior slope of the tibia. We have to try for the straight knee, means 0 degree, full extension. You can try for -5 also, means up to 5 degree hyperextension also. FFD should not be left because it will be very difficult for them to walk once the FFD is present, because most of the time their muscles are so much wasted. We have to retrain the muscle again in new position, and once it is wasted and it is in FFD, so it would be very tough for the patient to walk. If you want to increase the flexion, you can increase the tibial slope up to 7 degrees. With every increase in 1 degree of tibial slope, you can gain 6 degrees of flexion. And in reverse, if you have FFD, then you should try to keep it on 3 degree, minimize the tibial slope, so that you can gain the extension, full extension.
Yeah,
Target is to get full extension. For varus, there are two school of thoughts. Most of us follow that varus should be 0 degree, but a new concept has come. The varus should be 3 degree. It's what they call is kinematic knee or something kind of this.
Yeah. I think what they've found now is that in trying to correct it all the way, you end up actually uh, affecting the kinematics of the knee. So they would leave it about 3 degrees. That's because part of the deformity is not actually in the joint, but below the joint.
Yeah.
We are more
Yes.
flexible. If we get 0 degree, then we follow one
That's
school,
quite
and if
yeah.
we see 3 degree, then we follow the other school.
And but the other important thing is you have to get full extension on the table, especially in the osteoarthritic knee, because they will not stretch out anymore. In fact, they will tend to flex up rather than extend out. Okay, so if you don't get it on the table, it's very difficult to get it later. Rheumatoids may stretch up to about 5 degrees, but not more than that. So I think you have to make sure ideally that you get full extension. In osteoarthritis, even if you get a little more than full extension, you're happy. In a rheumatoid, don't get overextension because they can then get hyperextension problems. So you really have to be careful because sometimes the tissues at the back can stretch out a lot.
And so, probably I have got one term, sir, that constitutional varus, probably that on 0 to 3 degrees normal in some population. If you
Yeah,
that
so that, yeah.
maybe that is the reason. And sir, one more thing for the PGs, sir, there are few classifications which was given in the journal and book. One is Parvegi, which is on the basis of location. Another one is on the basis of degree. So for the exam purpose, sir, which one is, or for the surgical management, which one we should keep in our mind? Okay. Yes.
So which classifications are you talking about? Can you name them out?
Sir, one Parvegi classification they have given on the basis of area, sir. It is posteromedial side or anteromedial. It is like
What
that.
is it? What is the classification?
Sir, they have given like for varus knee also they have given one classification on the basis of which they can classify it on the basis of area of the joint which is involved.
Yeah,
Like
so
if
I
it is
think the standard classification that is mentioned is what you would follow, but these are all additional things. If you look up the literature, you'll find multiple people have tried to classify
that's what,
it in different ways.
yeah, that is
So
a
just
little
follow the
confusing.
standard ones, yeah.
Okay. And sir, when to decide we should go for a bony procedure? Because you have mentioned for the varus knee to soft tissue which we can release. So what else we can do if it is not getting corrected after that? If soft tissue balancing is not achieved after?
I think Ratnesh mentioned almost all the steps that you can do. The only thing which is for the medial collateral ligament, which is the other extreme, is to do a medial epicondyle osteotomy. That's the only thing I think he has mentioned, where some people, rather than release the medial collateral ligament, would do a osteotomy and sort of then change the position of the epicondyle so that the medial collateral ligament is a little more lax. That's the only other thing. And we are not doing the lateral side this time. There are a few things for the lateral side which you can do similarly.
Yes, just one question, sir, from the basics, sir, that how to identify the difference between normal bone and osteophyte. That few of the beginners, if it is getting him.
So normal bone, there will be always something underneath it, okay? When you get to the condyle, anything that is overhanging is osteophyte, okay? Well, once you get to the normal thing, there'll always be bone underneath it.
Okay. And another thing, sir, when we can use the constrained knee in case of varus?
In case of severe varus, where you anticipate that after everything, your knee is not going to stabilize, or when there is varus thrust and when there is very high FFD, you should keep uh, those revision implants ready, constrained knee.
So ideally, you want to avoid using a constrained knee unless you have to, okay? So if you find that in spite of everything, you're still having instability. So in these extreme cases of varus, very severe, uh, obviously revisions is one part of it where there's bone loss or a lot of bone loss. Always have, or very severe deformities, have that option with you, because by the time you release everything, you will end up not having enough stability in whatever knee you put in. So there you have to be. So there are grades of constraints as well. So you have a semi-constrained knee, and then finally you have a constrained knee. Different companies have different options available.
And sir, you have mentioned about wedges. What are those, sir? Wedges you have mentioned in the lecture.
That's part of the.
It's a wedge-shaped metal piece.
These are
Okay,
augments for
Bony defect.
defects. Okay, so the metal augments. You can have tantalum now with the. You have now also tantalum augments, which are what is known as what metal? Trabecular metal.
Trabecular, yes, sir.
And is it possible to do a TKR in fixed knee joint, sir? That is one Viva question.
It is possible.
Yeah.
Okay, they are. You can do it, but it depends on various factors. Okay, now if it's fixed and the soft tissue is not bad, then you can expect reasonable mobility. But if the soft tissue is also affected, like if it's a post-traumatic or post-infective knee, then don't expect too much movement in that. Yeah, but if you have a good quadriceps, which is mobile and soft, then some of them can get fairly good movement even after it's in arthroplasty. Obviously, technically much more challenging. You have to be careful you don't damage structures at the back. So you have to do this before you do your cuts, etc. Sometimes you have to cut to separate the two sides before you can do your further cuts. Okay. You may have to consider doing tubercle osteotomies, etc., so that you don't damage the quadriceps expansion, or a other side where you do a quadriceps snip or something like that to get adequate exposure also.
So,
But in that case, what would be the better treatment for fixed bony ankylosing of knee, sir?
So if it's just a deformity problem, you fix it in a straight position.
Okay.
Okay. If it is a straight knee and it's ankylosed, nothing you need to do about it. If the patient is happy with it, inform him of the problems and the risks, and then if he still wants surgery, offer it to him. If it's fixed in a functional position or in the correct position, which is in 0 degrees flexion and no varus valgus, then you can leave it. Okay.
Yes. Okay.
Eventually, after all, for a lot of situations, we end up doing an arthrodesis for a knee. Okay?
Yes.
But if it's fixed in flexion, he will have trouble walking. Okay? There's a significant deformity, you need to correct that. Varus valgus.
so also one basic question for the beginners, sir. If it is during the exposure, if there is a nick in the patellar ligament, sir, so what it should be done? Like it should be get repaired, or when we should repair it? If it is just a nick, partial cut in the ligament.
Partial cuts are not going to harm your TKR, but if it is a big cut, you need to repair it as in standard manner. You repair the patellar tendon and try to avoid flexion more than 60 to 90 degrees.
Yeah, so if you cut it with your knife, then repairing it is usually not such a problem. The problem is when it comes off the attachment.
Yeah.
Okay, so because it's osteoporotic bone and deformed or a knee which doesn't flex much, as you're trying to evert it, you can actually avulse the tendon of the bone. And that becomes a bigger problem to deal with because the bone is porotic. Then you have to think of various methods of securing it. You may even have to think of augmenting it with some tendon graft or something like that. Nowadays, you have some options with things like suture anchors and other things which were not there available before, but then you have to be very careful in mobilizing them also.
So
The main idea is to avoid doing it. Okay, so the important thing is care when you're doing your patellar eversion or retraction. When you put your levers, don't pull too hard on it. You can put in pins into the patellar tendon to avoid that happening at the insertion. So you can put in some pins so that if you're finding it's very tight and you are going to have to pull on it, put those pins so they prevent it from avulsing off. Okay. But the main thing is care and caution.
And so previously
And if you are anticipating that problem, then sometimes doing a osteotomy before you, so you do a prophylactic tubercle osteotomy and that you repair it so that it will not go off the bone altogether. So that's where say if you have a very stiff knee, sometimes it's better to plan a tibial tubercle osteotomy or a quadriceps snip before during your approach itself.
So previously we used to see much more patellar implants in the TKR. Now it is not so common. So what is the reason for that?
That's $1 million question.
In Indian population, the thickness is very less, so there is chances of patellar fracture. You must have at least, I think, 18 mm of bones should be enough for cutting for that.
Yeah, but even if you do have it, a lot of people will not replace the patella. So you have people who always replace the patella, others who never, and people in between, okay, who sometimes replace it if it's very bad and if the patella thickness is adequate to get you a button or whatever. So there's really very little hard evidence in the literature as to what is better. So you had papers which said you had to do it, others which say it's actually worse if you do it. I think that's a personal training thing that you go through. We hardly ever replace the patella, but there are some studies which show that with the posterior stabilized knee, maybe doing the patella reduces the revision chances. But then you have to be sure your patella thickness is adequate so that so it's there are no hard and fast rules. Ratnesh, what's your take on that?
Yes, sir. Actually, there are conflicting evidence that doing this is better than not doing it. Some people advocate to use, but in Indian population, it is very tough to do because in most of the cases, patella is so thin. If we try to do it, there is high chances of fracture. Leaving 18 mm patella is very tough, and if we cut less, then it will be overstuffing in anterior.
Stuffing. Yeah, but having said that, I remember initially we were replacing all our patellas. I don't think we had any problems with that. It's just that of course, there will be some patients where the thickness is so much that you can't do it. Okay. So I remember one patient, we actually ended up not putting the patella because what was left so thin. So we actually took off the articular surface and did not replace the patella because it would have overstuffed the knee. And she did really well. That knee lasted for more than 20 years, believe it or not.
Some surgeons prefer to do only cutting the articular surface and not doing anything.
Yeah, so that we did that because we didn't have a choice at that time, because if we tried to put it, it would have become too difficult to close because it was a really stiff knee. And if we did, so we ended up doing it, but we couldn't replace the patella. We just left it, and surprisingly, she did really well.
And
it's not something you plan to do before normally.
okay.
Sir, one question.
Yeah.
पोस्ट टीकेआर स्टिफनेस को प्रिवेंट कैसे कर सकते हैं सर, और उसका मैनेजमेंट सर?
Preventing stiffness.
यस सर, पोस्ट टीकेआर.
So your technique, and the second is your post-op mobilization. Yeah.
Yes sir.
Most important thing is to keep your knee in well balanced position. If you are tight in either in flexion or extension, it will be painful and patient won't be able to perform normal physiotherapy. So tissue balancing is one very important factor, and a second, definitely physiotherapy has definite role to avoid the.
So those are the two things: technique and mobilization, exercise, etc. So if you do it right and then mobilize them right, usually, of course, there'll be exceptions. The more stiff the knee is to start with, the less range of motion they seem to get, and the more mobile knees get more range of motion. But your technique, physiotherapy also make a difference.
And sir, treatment sir, suppose the one patient come after TKR, post TKR stiff knee, in which TKR was done at different center.
So you have to find the cause.
Yes sir.
Okay, and then you have to look at what the options are. So it is known as arthropfibrosis. Okay, so you can think of arthroscopic releases, but you have to be really careful. Okay? You're not going to damage anything when you're doing it. Okay, so you release all the suprapatellar adhesions, the parapatellar adhesions, and then try to mobilize the knee. Okay. You have to make sure it's not infected, in which case they're going to need a revision. So first thing is to find out why it's happened, then deal with the cause of the problem.
And sir, why most common adhesion occur in suprapatellar area, sir?
Why?
Yes sir.
Where do you expect it to occur?
But usually we find sir in suprapatellar area is the most common cause.
If it gets stiff in extension, that's where you'll get it. It's the quadriceps which is to some extent responsible. Why it is more, it's never just in the suprapatellar region. When the suprapatellar region is involved, the parapatellar regions are also involved.
Yes sir.
And if there's any intra-articular, so in a TKR, you will unlikely to get intra-articular adhesions because that has already been changed. Okay, it's stiff. You understand? Unless
Yes sir. Yes, sir.
In a normal knee, in a knee that has not been replaced, then if you have intra-articular adhesions, that can happen. But not can get intra-articular lesions.
Sir, one question regarding the cementing, sir. Is it what is the ideal way of putting cement, sir? And another one is it cement implantation syndrome? Is it can occur in TKR or not?
To answer your second question first, unlikely because two things. One is you're not actually putting it into the medullary canal as much. Okay. Second thing is usually the tourniquet is on when you're doing it that time. So it's less likely, but it doesn't mean it can't happen. Okay. The best technique is still, there's still again some controversy about it. Some people feel that you should only put the cement as a thin layer on the surfaces. You pack in the stem part of the tibial tray, then when it comes to a revision, it becomes harder to remove. And others feel, no, you should do it all the way so that you don't have to revise it. So I think
The best technique is one, first they prefer to use vacuum mixing, which is quite common in Western world. They have the equipments ready. Second thing, what they advocate nowadays that layers of cement should be on both sides, both on the bone and on the implant. It gives better stability long term. But the concepts are always changing, ever changing. This is the
I think I think we always put nowadays, almost everybody puts it on both sides. The controversy is whether you pack the canal with cement or not. Some people say only put it on the surface so that the peg is not full of cement, so that when it comes to a revision, it's not so difficult, because when you try to take out the peg, that's when you end up maybe losing a lot more bone. So I think it could be age related. In a younger patient, don't fix the peg too much. In the older patient, do it so that you don't have to ever come to revise it. So I think you have to make a judgment.
And so, few people suture it in flex position. Few prefer it in different, like in extension or in more flexion. So, what is the ideal one, sir? It is also. It is.
I don't think there is any recommendation for this. It's all personal.
Important thing is that at the end of it, you should be able to put it through a range of motion without the sutures being yanked off. Okay, if you can. So once you've done your repair, I mean the skin of your capsule, and then you should put the knee through a range of motion and make sure that it's not too tight. Okay.
So, I think most. Yeah.
Yeah, great. So thanks, Ratnesh, and
Thank you.
thanks to Ortho TV for their support. And I think until next time.
Thank you, sir.
Bye.
Thank you,
Thanks,
sir.
Sure.
Thanks. Thank you, sir.
Thank you, sir.
Bye. Good night.
Good night.